All right, so here we go. ICD-10, but let's start off with ICD-9. I mean, you know what? After a certain age, I found I kind of like things to be routine. You know, I get up a certain time. Nowadays, I don't even need an alarm. You know, my body wakes me up, right? Okay? You know, and it's kind of like it's nice to be regular in many different ways, right? Okay? If you know what I mean, okay? But it's like, why do they have to change ICD-9? You know, it's that, that politicians, Obamacare, Medicare. It's none of that. It's the World Health Organization. Who? Yeah, who? Okay? It's the World Health Organization. They changed this. And that's because ICD codes, which have been around since the 1900s, are used for global data. Recently, we had problems with Ebola. Not we, they, right? Luckily they. But we had Ebola in this country. How many cases of Ebola were diagnosed worldwide? The World Health Organization takes care of that. So as they found that there were more diseases, conditions, disorders that they discovered, there was no room to put them in. An example, H1N1 virus. They have a code for H1N1 virus, and they had no place for the codes. So they made up a code, and they ended up having to put it in the obstetrics portion of the codes because all the other sections were full. Then the H1N1 virus mutated. It was H1N1A, and so they had to have a different code. But when you think about it here from our perspective as a chiropractor, we want to be good doctors. We want to take care of our patients, and it's all about the patient, really. And so when we report these things here, we want to let them know, hey, this patient is not your typical patient. This patient has, quote-unquote, chiropractic baggage. They might have degenerative disc disease, spinal stenosis, and you know what? Toggling them one time is not going to cut it. All right? It's going to take a little longer for them to heal. But yet, under the current system, as an example, 847.0 is a cervical sprain and a cervical strain. Well, a sprain is a ligament injury. It takes 3 months to a year minimum to heal, if ever. A strain is a muscular injury. So we're trying to be good doctors. We're trying to diagnose this patient, examine them, and diagnose them properly, and report the codes because we have to, not only for reimbursement, but so that if something happens to us, any other provider can step in and know what you have been doing for that patient and what the problem is. But yet, we're using it interchangeably for sprain and strain. That's now going to be split out. It's now going to be split out. All right? And so the global data, as medicine advances, we can't right now. Keep in mind that in the United States, we are the only healthcare system in the world that uses ICD codes for reimbursement. Did you know that? The other countries don't need it. And the reason is because they have national health care. They have national health care. It's a case fee. Now, in some parts of the country, I was just teaching last week in Las Vegas. I know, it's a tough gig. Somebody has to do it. But I had my Elvis sideburns on, so they didn't notice me, okay? And the doctors from New York who were in my class were raising their hand and saying, no matter what we do, we're paid a capitation fee, $300. That's the way things are going. How much are you going to get paid? Do you think it's going to be less and less, or do you think it's going to be more and more? Less and less if you don't do the right thing. Somebody, before class asked me about PQRS, Physician Quality Reporting System. PQRS is mandatory, number one, but it's the government's way of actually doing research. And if I ask you as a chiropractor, do you reduce pain in your patients? Yes or no? Yes or no? Are you hesitating? Yes. Prove it. the government has been doing a study since 2007. Do we improve their activities of daily living, their outcomes, their function? Yes or no? Yes. And it's so easy. PQRS is just 2 codes that you have to report. But whatever you do this year, 2015, by the way, is going to affect us in 2017 because all of us doctors will be assigned our own value-based modifier. And the value-based modifier is that the better doctors, and I know that's what H&S has been trying to do, is trying to make their doctors better. The better doctors will actually get paid more. Pay for performance. Because one doctor's office, and this is a true story here, is October 31st. I went into his office. From January 1 to October 31st, on a Medicare patient, I'm using that as an example, he put an AT modifier on all of them. He saw the patient 168 times. Hey, why should he do less? Why should he do less? If he does less, he gets paid less. There's no incentive to toe the line and get paid, do 6 visits, is there? But yet, we all want that for a better practice and a better profession. So the government said, you know what, we understand that's a weakness in our system, and it will be changed. It will be changed. And so now the government is saying, if you're a better doctor, PQRS, EHR attestation, and then what they call the QRUR. If you don't know what that is, you might want to look it up. It's Quality Resource Use Reporting System. And it's basically, they look at how you rate, customer satisfaction. That's why if you go to the hospitals nowadays, okay, even in the ER, before, they get the paddles ready, they go, are you happy with our care? And you go, yes. And then they go, okay, all right? Because they want to make sure patient satisfaction that is there. That's because of QRUR. And you all, and me too, you can go to cms.gov and you can just do a search for QRUR and you can look up yours because as of September of last year, they released it for every provider with Medicare. Whether you're par or non-par, it doesn't matter. Non-par doctors still are being rated, okay? All right. It's for quality reporting, quality resource use report. All right, so 1993, the World Health Organization went to ICD-10, and who is responsible for maintaining the ICD-10? Now, somebody help me out. Doctor, right here in the front, right here. How long have you been in practice? 34 years. How many cases, just in your practice here, okay, how many cases of mongoose bites have you treated? I'm just curious. You don't remember any. Exactly. You see, out of all these 70,000 codes, there's some that are endemic to the United States, and there's others, mongoose bites, that you're just not going to see too many of, right? And so the World Health Organization told each country, we want you to do your own clinical modifications of the codes you're going to use, okay? And so those clinical modifications that were developed by the National Center for Health Services, that's what we currently are going to be using. Now remember, ICD-10 with the World Health Organization is for reporting of the data, the prevalence of these different conditions, all right? So when we looked at it, Australia, okay, the first one to ever go to ICD-10 was Great Britain. Even in Canada, of course, it's ICD-10-CA, okay, so it's their favorite letter in Canada. All right, okay, I guess we won't go there. Okay, all right. So in the United States, you will see 2 different coding systems for ICD-10. The top one, ICD-10, clinical modification, CM, is what you will use in your office. You will not use PCS. PCS is for inpatient hospital care, okay? So anytime you're reading this, you're going to go on CMS's website, you're going to be looking at things, you're going to go on H&S's website, and H&S will probably cull it down and say, okay, just ICD-10 CM, but you study CM. Okay? So just to direct you so you don't waste your time. Okay? So number one, some of the revisions. Information relative to ambulatory and managed care, expanding the injury codes. Now, what was the patient doing? Was this due to a car accident or a work injury? Don't you hate those questionnaires? Yes, but you know what? Those should be gone. Why? Because the codes, and depending on the carrier and maybe even H&S, they're going to direct you on some of the injury codes. You got to look at their policy, how it will be there, okay? There's some combination codes that we'll go over today. Now, it's like, oh, how boring, okay? It's stuff you use all the time. Like when a patient comes in with sciatica, do you expect them to have back pain with their sciatica? Do they have to have back pain? No. You see, so now we're going to have combination codes. The ICD-10, World Health Organization, said, we expect that certain conditions will always be paired together. And so rather than coding two different things, it's more specific. We'll just have one code that will be for leg pain and back pain together. We'll have another code that is just for leg pain, no back pain. And that's why some of these codes you're going to look at, you're going to say, this is ridiculous, but you have to have like a root code, and then after that, more specific codes, okay? Laterality. There's going to be a code for the left side and the right side. You will learn how to do that, and you know what? You don't need a book to learn how to do that. It is so easy, even a caveman can do it, okay? We've got a reserved table back there just for the caveman, okay? They're all back here, okay? All right? So the key is, the problem is they have no watch, so they are late. Okay, all right, okay. Anyway, laterality. Why do we care? Well, let's say that you send in a claim and you're treating the patient, let's say, 6 times for carpal tunnel syndrome. 354.0 is the code for carpal tunnel syndrome. The patient says, Doc, you are the greatest. I hear that all the time, right? I go, that's what my wife tells me to. No. She's rolling her eyes. Okay, so the key is, all right, is you have a code, and so you have so many visits for that code. Now let's say you tell the patient, you know what, you're doing great. If you have any problems in the future, give me a call, and you release them. Let's say a month later, patient comes in, says, Doc, you'll never believe, it's the darnest thing. I now have it in my left arm, my left hand. So it's 354.0. And all of a sudden, the carrier sees all these codes for 354 after a gap coming through again. So they send a questionnaire. But as of October 1st, 2015, we now will have a code for the right side and we'll have a code for the left. And so now they don't have to send a questionnaire, and you'll say, don't waste my time. Here's the code, the proper code. Now, I'm not going to criticize anybody, but there is a national speaker out there right now who is saying it's so easy, you just convert this code to this code, okay? And they're giving you unspecified codes. Now, I'm sorry to speak that way in mixed company because unspecified is a dirty word in ICD-10. Whenever possible, you want to stay away from an unspecified code. As an example, okay, Dr. Binder, Steve Binder here, okay? I'll be talking to him and I'll say, Steve, I'm treating this guy for shoulder pain. I don't know what shoulder it is, though. And he says, oh, no problem, okay? Reimbursement will be easy. Should you be reimbursed for that? No, but there is a code for unspecified shoulder. But then there's one for the right side, one for the left. Why would they do that? Because it's the ICD-10 and it's for global data. It's based on your documentation. Your documentation has to support, and that's an easy example, and you'll go, well, of course, Mario, okay? But if I told you that the patient has a spondylolisthesis, and then you look at me and go, okay, yeah, but that's 24 different codes now. You must document the level of the spondylolisthesis. where it is present. And if it's multiple areas, then you might have multiple codes. We'll go over all that here today, okay? So basically, as I said, the quality of your care is going to be measured, not just by Medicare, but by every insurance company. Already, the value-based modifier, Aetna, as an example, has already indicated they're going to go to value-based modifiers. I'm sure United Healthcare will probably be next because they follow Medicare. So look for changes occurring, okay? And so they're looking for public health threats here, and of course, meaningful use as well in healthcare. All right, so ICD-10 is entirely alphanumeric, which means all the letters are used for the different chapters except for the letter U. Now, I don't understand why they didn't use the letter U, because they said that U looks like too much like a V. You know, and I would say, you know, please put me on your committee, and then I'll show you the real alphabet, okay? But some chapters have been reconstructed, and in fact, with ICD-10, everything, if you know about ICD-9 now, everything you've learned in the past is going to be thrown out. The chapters are completely restructured. We've gone from 17 chapters now to 21 chapters. It's actually much more organized. Okay, so for any, you know, any compulsive people out there, you'll be satisfied with this system. Okay, all right. So there's confusion. You know, there's a 3 or an S. The biggest one are 0 and O's. Any of you treat pregnant patients? Anybody here? Okay, yeah. Well, O is for obstetrics, but it looks like a 0. And so you might be saying that the patient is pregnant, and in fact, you say that the patient, you know, has a mongoose bite, okay? All right, whatever it might be. So, you know, a 2 or a Z, be really careful. And I will tell you, it's kind of like in your action steps. If you are, you know, what is your telephone number? Well, it's 433-2405. Okay, you need to get off of that habit and call an O as an O, a 0 as a 0. Because literally, if your staff says to you, doctor, what is the code? And you'll say, you know, it's an O when it should be a 0, that is going to change the whole ball game here, okay? Especially when Ralph is pregnant, right? Okay, because that might, you put the wrong code on there, okay? All right, so unspecified codes are some of the pitfalls here. I've talked to you about those pitfalls, all right? Does that mean that you can't, you know, take any unspecified code and throw it out? The answer is no. You would never want to do an MRI just to tell me the ligament that is sprained in a wrist sprain. Now we'll say the patient has an ankle sprain. If you say, well, what ligament is it? I can tell you what ligament I think it is, but I won't know unless I do an MRI. And I'm not going to do a $2,000 or more or greater test just to tell you a more specific code. So if you know it, if the patient said, I had an MRI of my ankle, and they said, I have a sprain, get that MRI report. Be more specific as far as which ligament it is. Okay? But the key is, there are times where an unspecified code would be fine. All right. So, October 1st, 2015, do we all have to go? Does every insurance company have to switch over to ICD-10? The answer is no. Only those that are under HIPAA. And then they laugh, you know. Which ones aren't under HIPAA? Well, the ones that are not under HIPAA are PI and work comp cases. All right. Now, I actually talked to a person, a regional manager for State Farm. They said, we most likely will go. But if it's some small insurance like Beaver Insurance, maybe they won't go right away, or there'll be a transition, whatever. So therefore, make sure that you're checking with your carriers, with H&S as well. They'll tell you, they'll have their hand on the pulse of the insurance in this area. Okay? But just be aware that a work comp or a PI case doesn't have to go, And so call at 3 in the morning, maybe you'll get Jared and talk to him. The commercial, okay, all right. State Farm has about 30 miles from my house. State Farm has a corporate office. In that commercial, did you ever see that? You know, who are you talking to at 3 in the morning? You know, Jared, yeah, sure. You know, who are you? That was actually a State Farm rep on that commercial. That was actually there. It was from Bloomington, Illinois. So, all right, anyway, trivia for the day. Okay, here's an example. Just read this along with me here. A patient is a delivery person for a florist. While delivering a bouquet of flowers to a person at a workplace, they slip and fall on untreated ice in the parking lot in the workplace. In the fall, they fracture their wrists. Is the party at fault the workplace, or is there work comp claim? And you get these questionnaires, right? Asking, and then they argue it out. So while the insurance companies are deciding, the hospital does not want to wait, so they say to file it with the health insurance. Okay, health insurance will be ICD-10. ICD-10 codes are used. 3 weeks later, it's decided that the claim will be handled by the work comp carrier, and so now you have to convert it over to 9. That is a nightmare. You don't want to have two systems. You have two systems, or will have two systems in your computer if you do it right, starting Monday. You'll convert it in there. It'll be there. Okay? Now, oh, well, the software vendor hasn't done an upgrade. You do the upgrade. I will teach you how. It's very, very easy. It's not that hard. Okay? And now you be ready. Why? Because if you're not, you may not get paid. And you don't want to wait 6 months. All right? It's not that hard. I seriously will teach you how to do it. Okay? All right. So let's start to learn about these codes here and go through it a little bit more. Are we taking a break? Pardon? Okay. Okay. All right. All right. So since we started late here, 15 minutes, we'll be taking a break. So squeeze together. Okay. All right. Okay. All right. Okay. So ICD-9, we had 3 to 5 characters in length. Many of the codes, how many codes do you use in your office that are just 3 characters? I will guarantee you probably none. 354.0 is 4. All right? 722.52 is 5. Okay? We have 3 to 7 characters in length for ICD-10. How many will be 3? I don't know of any. You'll have some 5s, 5 characters long, and they always start with a letter. So they always start with a letter. So it'll be like M 45 point whatever, okay? So we're going from 17,000 codes, which you don't use now, to 70,000 codes, which you won't use next year. Now, are you going to be sticking to your 2 codes or 30 codes? No, you'll probably have 100 codes. All right? The first digit may be alpha, 2nd through 5th is numeric. Here, the first character will always be an alpha character. Now, just so you take in a little note there, the alpha character, which means the letter that it starts with, you want to get used to it. Don't confuse it with CPT codes. I'll be talking to you about S codes. And then you think about, oh, is that like S8990? No, that's a CPT code. We're talking about S codes, which actually are from Chapter 19. And you will be using those in your office a lot. And those S codes there are ICD-9 or ICD-10 codes, rather. Okay? So make sure that you know the difference there. Okay? You'll have very specific detail. Insurance companies will know, they know the rules. And they're going to be looking for the detail. How do they look for the detail? In your documentation. Now again, Medicare is not the only one out there. Medicare, they're the ones that publish it so we see it, but all other insurance companies have their own policies, both internal as well as the ones you can read. And so Medicare said that audits are actually, and they just said this a couple weeks ago, are actually going to go up as a result of ICD-10 at the beginning because we're going to make sure that you're using the right codes. And when I send in documentation, which is very rare, but I'll send it in on occasion, I never hear back. Is that a good thing? Yes. Doctors always say to me, I send it in, I never heard back from them. Should I call them? Are you nuts? Keep your cloaking device on, okay? If they don't call you back, if they don't send a letter, you're okay. You know, they don't pat you on the head and say, good job, okay? All right. All right. So, number one, specificity. Look at your documentation. The documentation will have to be detailed. I am sorry. The day of the travel cards, and hopefully there's nobody out there still using a travel card. And literally, I was teaching at Palmer, Florida 2 weeks ago. Someone said, how can I put all the information you said on one line of my travel card? You don't use a travel card. It's over. Save some paper. Do a proper note. I understand. It's not, you know, the Mercedes 80s are gone, all right? So unspecified codes do have an acceptable use here if that is the most accurate that you know. All I know is they sprained their wrist or they sprained their ankle. That's fine, okay? All right. So whenever possible, number one, if they happen to, you know, I went to the ER and they ended up doing an MRI of my ankle. They said that I have a torn ligament. Which one was it? I actually asked one of my patients that. He said, well, it was a talofibular ligament. Okay, I have smart patients, all right? But if he goes, I don't know, then you get the report. So many times doctors will say, patient went to the ER, had this done, you know, x-rays, MRI, CT, and that there's no report in the file. Always find out what the patient had. My staff, I'll tell them when a new patient calls, it is part of their intake that they will ask the patient, have you had any x-rays, MRI, or CT scan? They go, yes, it was 5 years ago, still get it. Because if they had degenerative disc disease 5 years ago, they've got it today. So make sure you always get that past information as well. All right? Okay. So the non-specific codes, steer away from it. I will tell you that on most non-specific codes, from what I know and what I've seen and what I've heard, is that those will probably be denied. Not all of them, but, you know, especially when it comes as chiropractors to the spine, yeah, it'll be denied, all right? The specificity is, if you will, the buzzword right now. You know, when a patient comes in and they're pregnant, and I will have a section in your notes here today about pregnancy, now it's like, what is your due date? Well, due date is one thing, but my staff, and Laura, who actually goes in the rooms with me, and she's my scribe, if you will. We use EHR. I've trained her to put it in there. That way I see the patients, and I have my hands on those patients. Okay? And, you know, doctors, I was teaching in Napa Valley, California. Tough gig. Somebody's got to do it, okay? And the doctor said to me, I'm 80 years old. I am not going to go to EHR. I said, you know what? Hire a high school student. They're texting when they're 3 years old. Train them, send them to class, and train them. You see the patients, document it properly. Okay? Because if something happens to us, we want someone else to step in and take over that case. So if a patient comes in and they're pregnant, ask them not just what is your due date, ask them how many weeks pregnant you are. Because literally, I'm not mincing words here, the code, when you're doing a pregnancy-related, like back pain due to pregnancy, they're going to come in, and if they're 18 weeks pregnant, you're going to be using a code, and then say, okay, see me in 2 weeks, you're going to use a different code in 2 weeks. See me in 3 more weeks, you're going to use a different code in 3 more weeks. But it's so easy. Don't leave early, because I will teach you how to do that, and you won't even need a book to look that one up. Okay? All right. Ordinality. Okay, so now, before we go on break, don't be packing up yet, we're not going yet, but the buzzword out there, okay, anyone who walks out in the hall and you come up to them and go, what's the password? They have to say ordinality, okay? Ordinality, and ordinality, you get a free cookie if you say that, okay? Okay, or a bran muffin if you have that look on your face, okay? All right, okay. So this table right here, there's 4 of you sitting. Okay, Parker, you're number 1. Steve, you're number 2. You're number 3. You're number 4. That is the ordinality in that table, on that table. Ordinality is the order in a line that they are. Okay, what phase of care is the patient in? Is this in their initial active care, or is it subsequent care, or is it a sequela? That will all yield different codes, the ending of the code. And that's the ordinality. Ordinality is the buzzword, if you will. It is the order, okay? So codes have to be supported by the patient's documentation. They are more specific here. The American Academy of Professional Coders says that every doctor will be taking notes, spending about 15% more time in documentation. I understand. And I remember back in the 80s and 90s when I was getting carpal tunnel and it's like, oh, okay, but you know what? I write very little now. Why? Because nowadays you have EHR and you have Siri, right? Okay, you can even dictate, even, emails I dictate most of the time. All right, so you don't have to spend time typing. The key is here, always try to use technology to help you out in life. Why? Because you can see more patients that way. ICD-10 allows for greater specificity. Do you see a pattern here? I want to drum it into your head. All right? You want to look at that specificity in your notes. All right? So, if the documentation is insufficient, staff is going to be putting in an unspecified code. Not good. Documentation is not accessible at the time of reporting. Why? One office said, our doctor, he's 3 months behind in his documentation and coding. Not good. Okay? No doctors with H&S, okay? The billing used by the provider has an overabundance of unspecified codes. You will be profiled. You're going down, okay? All right? And the provider uses codes that they have committed to memory. Instead of updating here, you can't commit it to memory. You can't commit it to memory. All right? That's why we have computer systems nowadays. All right? And very few doctors have the codes committed to memory now as it is. Okay? All right. Okay, so time now is look at your notes. I'm sure that H&S looks at your notes anyway. The documentation, they have things online, webinars, okay? And it's me. I was in Charlotte, North Carolina at H&S headquarters teaching a class on documentation a few years ago. I got to know my audience very, very well, okay? It was 2 guys, but they loved me. And in fact, they knew documentation better than most of you by the time they were done, okay? Because they couldn't fall asleep in the class, and there was no coffee there, all right? They liked me so much, they came back again, and they're sitting in the back there, as these guys over here, okay? All right? I said, I've seen you before, and then I reminded them, they go, oh, yeah, okay? And they said, well, they must have liked you, they had you come back. I said, either that or we all 3 don't charge enough, right? And they had us all come back, right? So it was kind of funny here, but the key is that still, even what I taught 3 years ago for H&S is still appropriate. It's still the same documentation, okay? All right. So if you want, we're going to take a break. Now, I just want to be kind of honest with you here, okay? I really love to teach. And part of the reason why I love to teach is that if I give you less than what you paid me for, you actually like me more. Okay, in other words, you're taking the class today, you paid for it until 4:30. If I let you out at 3, you love me more, okay? It's not going to happen, okay? All right? No, you're smoking a bong. I mean, there's just, are you from Colorado or what, okay? All right. So we're going to take a 10-minute break. That's on our time zone, not yours, okay? If you want to, we have webinar special on the books there, and Jenny can, she loves cash, she loves check, but we'll take credit card too. And so it's $60 for the book, but it's everything you'll need, and it's all pre-washed, as I told you. Okay, so I just made that up. So anyway, it's there, and Parker has an announcement first. Okay,
Well, I was just going to say that there'll be, since there's such a short 10-minute break, we will have time during the hour-and-a-half lunch if they want to buy the book as well.
Yeah.
Not that they can't right now. And there's muffins and donuts and coffee outside the doors.
And what's the password for the muffins and the donuts? Ordinality. Okay, take a break. Thank you.